بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الخامسة، نرحب بكم اليوم. محاضرتنا about childhood asthma and allergy will be in two divided parts. As you know, asthma can be defined as a chronic inflammatory disease of the airway with the following clinical features. It is characterized by episodic and or chronic symptoms of airway obstruction. There will be bronchial hyperresponsiveness to triggers, evidence of at least partial reversibility of airway obstruction, and must be excluded other diagnoses. This is the most common definition of asthma. And you must know that asthma is one of the most common chronic disease in childhood. Affect about 5 million children younger than age of 18 in US. It affects 1 in 13 school age children and is a leading cause of office and emergency department visit, hospitalization, and school absenteeism. Mortality nearly doubled between 1980 to 1993, with more than 5,500 fatality annually. As etiology of asthma can be, it is multifactorial really. There is collaboration between environmental and biological and genetic risk. Environmental presence of allergen, infection, microbes, pollen, stress, and biological and genetic risk like immune, lung repairs, plus the age. All these lead to the innate and adaptive immune development in atopy. With lower airway injury, there will be respiratory tract infections, especially in the childhood, aeroallergens, pollens, toxicants. These lead to the apparent repeal. There will be persistent inflammation, airway hyperresponsiveness, remodeling, and airway growth and differentiation. All these lead to the asthma. So it is multifactorial causes of asthma really. As we define as it's a chronic inflammatory disease, so there is a role of inflammatory cells like mast cell, eosinophil, T lymphocyte, neutrophil, and whenever there is cells, so there is a chemical mediators like histamine, leukotrienes, platelet activating factor, bradykinin, and chemotactic factor like cytokinase and eotoxin. All of these lead to the inflammatory process found in the asthma. As a result of edema, there will be an increase in mucus production in the lung due to influx of inflammatory cells into the airway and epithelial cell denudation. Chronic inflammation can lead to the airway remodeling. Please remember all this term remodeling, which result from proliferation of extracellular matrix, protein, vascular hyperplasia, and may lead to the irreversible. We define asthma as partially or complete reversible, but whenever there will be chronic inflammation, remodeling lead to the irreversible structural change and progressive loss of pulmonary function. Let me talk about the risk factor of asthma, childhood, presence of parental asthma, presence of allergen, atopic dermatitis, only atopy, allergic rhinitis, food allergies as indicator of asthma also, in inhalant allergen sensitization, food allergen sensitization, the presence of severe lower respiratory tract infection or pneumonia, bronchitis require hospitalization. One of the complications of long-term complication of bronchitis is development of asthma, wheezing apart from cold, male is a risk factor also, low birth weight, plus environmental tobacco smoking exposure. There will be what we call asthma predicting index. Identify high-risk children, 2 to 3 years of age. If there is more than or equal to 4 wheeze episodes in the past year, at least one need medication or medical diagnosis. Plus, there is a major criteria and minor. Major criteria: parent asthma, eczema, and inhalant allergen sensitization. Minor criteria: allergic rhinitis, wheeze apart from colds, eosinophil more than 4 or equal to 4%, food allergen sensitization. So there is wheeze, and one major criteria, there is wheeze, and one major and the two minor criteria is high predictive index of asthma. Let me talk about the type of asthma. You know, if you go in the many reference, there is many differentiation of asthma, but we can conclude in these two main asthma in childhood. There is a recurrent wheeze in early childhood, primary trigger to the common viral infection. Patient come with any viral illness, there will be upper respiratory infection followed by wheeze. Or there is chronic asthma associated with allergen that persists for later childhood and often adulthood. There is a third type of childhood asthma, typically emerge in the female, have obesity and early onset puberty by age of 11 years of age. We talk about trigger of asthma. There is a lot of trigger of asthma. The most common, and we will see especially in the clinical practice, is a common viral infection of respiratory tract infection lead to the asthma, and you see this a lot of trigger like animal danders, indoor allergen like dust mite, cockroach, mold, cockroach and صراصير, seasonal aerial allergens, pollen, tobacco, air pollutions, strong anxious odor or fumes, perfume and hair sprays. So these risk factor, genetic, lead to the bronchial inflammation, and presence of this trigger factor lead to the bronchial hyperactivity and trigger factor here. All of these inflammation lead to the edema, of bronchoconstriction, and increased mucus production. See the triad of the inflammation, edema, bronchoconstriction, and mucus production increment. All these lead to the narrowing of airway and lead to the symptoms, which is most commonly cough, wheeze, breathlessness, and chest tightness. Clinical presentation of asthma. Children with asthma have symptoms, mostly it's coughing, wheeze, shortness of breath, or rapid breathing, and chest tightness. Mostly it's at night time, and this may be due to the decrease of the cortisol level in the body at the night. Rhinosinusitis, gastroesophageal reflux, and sensitivity to the non-steroidal anti-inflammatory may trigger or aggravate asthma. We'll talk later about this allergic rhinitis and GERD. Obtaining a family history of allergen and asthma is useful because allergic disorder running in the family as we talk. We have put in mind these signs and symptoms came in the different presentation, either mild, moderate, severe, and sometimes life-threatened. And this diagram is very simple diagram, and this is present in your book, which is illustrated textbook of pediatric. And this gives you an idea about the type of presentation, either mild, moderate, severe, or life-threatening. We talk about the clinical signs, talk about the respiratory rate, sitting, color, level of consciousness, use of the accessory muscles, level of consciousness. So if there is increased work of breathing, tachypnea more than 30, which is severe. There is chest recession, moderate, some intercostal recession, severe use of accessory neck muscles. Lative is a poor respiratory effort, is hypotonia. Auscultation, if there is a wheeze, which goes with a mild to moderate. Silent chest is a sign of life-threatened. Pulse, severe if there is tachycardia. Life-threatened, we'll see if there is exhausted, very important here, exhaustion, silent chest. Cyanosis is life, must be put in mind these signs of life-threatening condition with color cyanosis, exhausted, disturbed level of consciousness, silent chest, and pulsus paradoxicus also. If we use a peak flow meter, we'll see moderate is more than 50% than predicted, severe less than 50%, life is less than 33% of predicted. Oxygen saturation moderate is more than 92, severe in life less than 92 or maybe 90. So during acute episode, physical examination may reveal tachypnea, as we see, tachycardia, cough, wheeze, prolonged expiratory phase. Physical finding may be subtle or classical wheeze, may not be prominent, especially in the minimal air movement. As attack progress, the color means cyanosis, diminished air entry, tight chest, chest retraction, agitation or inability to speak. Tripoid position, which is this is the tripoid position. It is sign of severe asthma, severe attack of asthma. Diaphoresis, pulsus paradoxicus mean decreased blood pressure with inspiration more than 15 mm mercury can be observed, especially in severe to life-threatening. Physical examination may show evidence of other atopic disease such as eczema or allergic rhinitis. This is a chest retraction, you can see very clear here, chest retraction, intercostal recession. As we talk in the first two slides, we talk about the asthma. We must exclude other causes, mimic asthma. So differential diagnosis of the cough, wheeze in infant and children. We'll talk about upper respiratory tract. Also must be differentiated from allergic rhinitis, adenoid, hypertrophy, foreign body, infectious rhinitis or sinusitis. Middle respiratory tract like bronchial stenosis, enlarged lymph node, epiglottitis, foreign body, laryngeal web and this TE fistula. Lower, the most common هو asthma, maybe bronchiectasis, bronchopulmonary dysplasia, chlamydial trachomitis and chlamydial infection put in mind mostly. Chronic aspiration, heart failure, cystic fibrosis and other as you see. In the first month of life, it is very difficult to diagnose asthma, especially really in the first year, very difficult, but even 30% of asthma can present in the first year. But first months of life, there is a wheeze and cough. Don't put in mind first the asthma, you put in mind these. Cradle means cystic fibrosis, respiratory infection, aspiration meaning swallowing or dysfunction, GERD, ciliary dyskinesia, lung or airway malformation like laryngeal web, bronchotracheomalacia, and edema like heart failure or congenital heart disease. For first few months of life, put in mind this cradle. How you diagnose asthma? It is according to the symptoms, medical history, symptom worsening at night and on awakening. There will be seasonal. There is presence of atopy like eczema, hay fever, family history. There is a trigger like animal fur, chemicals, temperature change, dust. Symptom respond to the anti-asthma therapy, bronchodilator, and calls go to the chest or at least more than 10 days. The family say, doctor, whenever this patient come flu, he will continue like cold symptom more than 10 days. So put in mind this is an asthma. Put in mind there is no diagnostic test to secure diagnosis of asthma. We use a tool like spirometer. We talk about spirometer in the second year of medical school, and we know how to use it. It's a most helpful, preferred method in establishing the diagnosis. As we see, if you remember that we use FEV, force expiratory volume in 1 second. If there will be an increase in FEV1, more than 12% or more than 200 ml after inhaled bronchodilator, we do FEV1 before and after bronchodilator. If it's more than 12%, so it is mostly asthma. Many asthma patients may have a negative, so must be repeated this test advice. The other way, other than spirometer, for peak expiratory flow, we'll see this maneuver is very simple, aid in the diagnosis and the management. So compare patient previous best effort. This home device we used at home, and we at least 2 reading per day, and we see compare this reading with previous reading and the best reading. So 60 liter per minute improvement after a bronchodilator or diurnal variation in the beef, more than 20%. This is also going with the asthma. A bronchoprovocation test, we use substance that induce a bronchoconstriction, but nowadays not used really. The methacholine or histamine or inhaled mannitol. Skin test or skin specific IG test for allergen, especially for the atopic. The objective of measurement of pulmonary function test is spirometer to establish the diagnosis and monitor diagnosis and treatment of asthma. Can be monitor the patient response to the treatment, a plan, assess the degree of reversibility with a therapeutic intervention, and measure the severity of asthma exacerbation. So children aged more than 5 years can perform spirometer maneuver, but in the clinical practice, as we do now, really this near more age, maybe 7 or 8 years to do this spirometer. This is a peak flow meter. The patient take inspiration and force expiration, and you see this this color. With expiration, we see a base effort, and this is used in the monitoring at home. Allergic skin test should be part of evaluation. Tests should not be done during exacerbation or wheeze, and this done at an allergist one, not a general pediatrician. Have a special skill in registration and interpretation of the skin test to determine the immediate hypersensitivity to the aeroallergy. This positive test result in correlates strongly with a bronchial allergen provocating allergen. There is other one who in vitro serum test that are RAS, rhabdoallergosorbent test, enzyme linked immunosorbent assay, another option to measure the antigen or to specific IgE. Chest X-ray can be performed, especially in the first episode of asthma, or with recurrent episode of undiagnosed cough, or with both to exclude anatomic abnormality. Mean not each patient with every time coming to the hospital we do chest X-ray. Only in this situation. Children with history of asthma do not need a repeat X-ray unless we see there is anatomical or there is pneumonia or there is a special finding. We can stop here and we continue in the next